Welcome to another episode of the PML podcast. I am Dr. Babajide Ogunsende. Today's episode, we're going to talk about a case of a patient that had previous back surgery about 10 years ago and had anterior cages placed into the lumbar spine. She did fantastic for about 10, 15 years actually. And then she started having some pain in the lower back that were radicular in nature. She presented to me with severe lower back pain going from sitting to standing, pain going down the leg, severe pain. Her x-rays before the surgery were like this. So she had previous lumbar fusion with cylindrical cages at L45 and L5S1. So these cages that you're looking at here were placed about 10, 15 years ago. So she started having pain below the cylindrical cages, which is a typical presentation of SI joint dysfunction. SI joint dysfunction is really an adjacent level disease that typically comes up years after you've had back surgery, especially a fusion surgery. So this is by definition, an anterior lumbar fusion with cylindrical cages. Her symptoms were so severe that when she drove in the car for a while, it was hard to get out of a car because of this severe pain. She had a CT scan of a lumbar spine. You really want to get a CAT scan or MRI of the lower back to rule out any herniation or any lumbar pathology. So in her case, because she already had existing titanium cages, you're limited by the MRI because MRI doesn't show well with titanium implants. So we got a CT scan of her lumbar spine and showed no pathology in the lumbar spine. So we know that this was not the area where she was having the problem. So we now had to rule out to check this level where she below her lumbar fusion. So what we did was she had an SI joint injection, which is a CT guided injection done by the interventional radiologist or the pain management physician. And she got about 75% improvement of her pain after she got the injection. Now, typically, I always tell patients, even if the relief is only for like 2 to 3 days, it is a positive test because if the injection was not in the right spot, they shouldn't get any relief in the first place. So insurance companies pay or they approve those injections. And for example, Blue Cross Blue Shield requires us to get 2 injections, sometimes a month apart, to confirm that this is SI joint related. So once we do the SI joint injection and you get over 75% relief, the patient has options. The options include, more injections, continue to live with the pain that they're having. In her case, her pain was so severe, even the hardcore narcotics could not relieve the pain. So typically patients that present with SI joint pain, we put them on Schedule 2 narcotics, put them on medications for nerve pain, which is gabapentin or Lyrica, as well as a muscle relaxant. So in this case, we exhausted all conservative treatments, including therapy for this patient, and the pain pre-op was quite severe. Now, her pain was intermittent. Sometimes she will have no pain, sometimes the pain is severe. So we decided to go ahead with surgery on her. And the amazing thing about her is she actually also had a cervical disc pathology. So on the same day that I did her SI joint surgery, I also did a cervical fusion, which is, unusual, but she wanted both surgeries done at the same time. So what we did was we did the PML technique. The PML technique gives us the advantage of being able to do one incision to address both SI joint pathologies, as well as in her case, I was able to combine that with a cervical spine surgery because it's one incision for the SI fusion, it's one incision for the cervical fusion anterior. She spent one night in the hospital because of her cervical spine surgery. She went home the next day. So what we did for her PML surgery is we made a 1 centimeter incision at the level of the S2 foramen, and then we put 3 screws over guide wires. Those guide wires are 3.2 millimeter guide wires. You check AP outlet views as well as the inlet views. Those are very critical views. The most critical view is the 15-degree IR view, which stands for internal rotation views, because these screws have to end up within the iliac teardrop. The iliac teardrop tells you that your screw is not inside the sacroiliac joint, which can cause more pain if it's in the SI joint. So these screws are typically about 65 millimeter screws. Sometimes I use 70 millimeter screws depending on the distance across the SI joint. So we use the 15-degree IR view on the inlet view to confirm the length and the trajectory of the screws. So in this picture that you're looking at, you can see This is a classic AP view that I use to confirm the trajectory of the PML screws. You have 3 screws going to the teardrop on both sides. The midline, you want to confirm that you're midline by checking the spinous processes. The spinous processes tell you that you're absolutely midline. The other view that you want to check is sometimes you have to check what we call the inlet view. The inlet view is also critical. So basically, it's the same kind of view that you're looking at in this image, and you have to make sure that those screws are in a 45-degree angle towards the iliac teardrop. So again, she had this surgery done. She had excellent at 6 weeks. She was 90% pain free. Currently, she's over probably 3 to 4 months now post-op. She has 0 pain in the SI joint. And we still talk today, and she still tells us how wonderful she's doing with her SI joint pathology. And also, her cervical surgery was actually very successful. Now, if you look at this view, this is a classic inlet view. So again, this is an AP view of the pelvis. This is an inlet view that you're looking directly into the pelvic inlet, into the pelvic brim. So you want to make sure that those screws are not violating the ventral wall of the sacrum. So again, PML goes from posterior medial to lateral. The conventional techniques go from lateral, so from outside in. You can see clearly the SI joint on both sides. Those screws are perfectly across the SI joint. The difference between this technique and the conventional technique is, for the conventional technique to get what you have in this technique, in the PML technique, you have to have 2 separate incisions. So some of those incisions can be 3, 4, 5 millimeters in length, centimeters in length, and then for the PML is actually 1 to 1.5 centimeters, 1 incision. And when you go from lateral to medial, there are some dangers here. You have the superior gluteal artery. If you hit that artery, you can lose about a liter of blood from hitting just a branch of the artery. So the PML solves the problem of the transection of the SGA, also solves the problem of the incisional pain after a lateral to medial approach. Because when you lay on the side where you've had the surgery, it's quite painful. If you have bilateral SI fusion using conventional technique, even if you use the posterior oblique lateral, which is the other option of SI fusion, which goes through the posterior superior iliac crest, through the ligamentous portion to the sacrum, that can also cause pain because you have to have 2 incisions. You can have injury to the cluneal nerves. Those nerves can form neuromas, which are very painful. The PML approach is 1 little incision, no restrictions after surgery. So these patients are really just up and about. They can drive within a week. The only restriction we tell them is no running and no repetitive squats, because when you do squats, you put a lot of stress on the sacroiliac joint. So this patient has done really well. Pre-op pain was pre-op almost 7 to 8 out of 10. Post-op pain currently is 0 out of 10. Again, PML goes from posterior medial to lateral, and then you can see here the AP view shows the spinous process in the midline. These are old cages. The risk factors of developing SI joint pain and SI joint pathology is previous lumbar fusion, female. Sometimes if you have a BMI over 30, it's a risk factor. Multiple children is a risk factor, as well as post-traumatic arthritis of the SI joint. There's a syndrome called Bertolodi syndrome, which is abnormal pelvis, which is also called the dysplastic pelvis. That's another risk factor for SI joint pain and SI joint dysfunction. So next time, we will bring you a case of a Bertolodi syndrome, a patient that presented with severe SI joint dysfunction, a normal MRI, a normal X-ray read by this patient's physicians, radiologists, but a closer look of her X-rays shows that she has what we call a pseudoarthrosis of the transverse process to the sacroiliac, unilateral. So that is a classic reason to have SI joint dysfunction. 30% of patients that have Bartholdi syndrome have SI joint dysfunction. Coming up next week, we'll have patients actually call in to give testimonials on how their SI fusion has been. All these patients were treated with PML technique, and all of them, most of those patients have 75 to 90% improvement in their pain by 6 weeks. So join us next week. We're going to have a live call in for our first patient, and she's going to talk to us about her pain before she had the PML SI fusion and her pain currently and how PML SI fusion has changed her life. The PML Masterclass starts January 1st. We're going to go in depth in Module 6, case presentations of 10 patients that have had the PML SI fusion. We show all the x-rays and we discuss in detail for professionals, surgeons that want to learn the PML technique. Like, comment, share, subscribe below. We'll see you next week.